It's the same one actually as I had back then, I'm afraid. Listen, thanks very much to the Dean and Thomas for inviting me to speak. The Quality Improvement Division has very important links with the RCSI, and it's a very valued partner in a lot of what we do, most obviously through the relation we have through the National Office for Clinical Audit, which we fund and the RCSI very effectively oversee and run, which is a very important initiative, I think. I thought Abigail's presentation was excellent. It really feeds in nicely to some of the messages I suppose I have to share, which are in part aspirational. I'll talk to you about things that I suppose I believe in and the division believes in and we're trying to get people signed up to. It clearly doesn't mean that we think it's all happening now and that everything's all fine and hunky-dory out in the front line, because we're very aware of the reality there. But the concept that Abigail kind of put forward, that everyone is a leader and everyone here is a leader, you've shown enough leadership to turn up today for starters, so that's a good start, and you'll pick up some ideas as you go through, and hopefully things that you'll be able to use when you go back. It's also great to see a quote from the Stranglers in your presentation as well. I don't know if any of you know who the Stranglers are. You're probably all too young, but no more heroes anymore. So where are we? 2017 now. I need to change the date in the slide, but we're under a lot of pressure. You all know that. Abigail's already alluded to the industrial relations environment, but a lot of that comes from the kind of pressure everybody's under. I think the front line is extremely stressed, demand continues to grow, we're probably not changing our models of delivery quick enough to keep pace with that. New technologies, inflation, costs, we may have had a realistic budget adjustment last year and we more or less broke even, but it led to a massive focus on finance last year and increasingly this year as well. I'm sure you're maybe feeling that either directly or tangentially. And that's a difficult environment to talk about quality improvement. We still have a very centralized command and control structures. And the real danger, I think, is when we break up the HSE, which I think we obviously have to do, it shouldn't probably have been formed in the first place, is that we end up with mini HSEs all around the country and that they in turn then adopt the same kind of command and control ethos, which doesn't work in healthcare, it's never worked anywhere in the world, and we're certainly not going to crack it here in Ireland. So we have issues also about public-private mix and inequity. I suppose I noticed that in my practice. I work with the homeless, entirely dependent obviously on public services, very good services when you get into them, issues obviously around access, and we all know about that. Lots of amazing things have happened though. I mean, I think if we read the newspapers, you wouldn't believe any of these things that happened. Phenomenal improvements on the basis of clinical people, nurses and doctors, physiotherapists, occupational therapists, people coming together who know frontline care and changing how it's delivered radically and really changing patient outcomes in absolutely demonstrable ways. I could tell you stories about many of these, but time doesn't really allow. But I think you're aware of those various initiatives, and I think they've been very, very significant. But this is the flip side, I suppose. This is what gets covered. I fronted into the media on a lot of these issues. So I suppose I've had first-hand experience of what the media agenda feels like, certainly. Obviously, the media is very important. And in some ways, some people would say the service only ever really responds when the media gets involved. And that's a terrible indictment, really. So the media is very useful and we need to work with it. But sometimes it feels a little bit unfair, I suppose, because those earlier stories didn't get any coverage at all. I could tell you stories about integration of the media as well, but maybe too many to tell you at the moment. Or other challenges, obviously access block is a massive problem in the emergency department. It's our front of house, it's a bad front of house really for people. As a GP, I hate referring people to the emergency department because I know what they're going to go through. And that's despite the extraordinary efforts that people make in the department to make things work okay for people, but it's just very overcrowded. Long waits for outpatients, lots of problems with recruitment and retention of staff. So that's to do with the work environment, and I'll come back to that. Still very limited measurement of quality. The Director General would ask me on occasions, he stopped asking me now because I always give him the same answer. When you look at the performance report, what do you think of it? From a quality perspective, and I say, I don't know. I couldn't tell you about the quality of our services really from what we currently measure and how we display the information. So we're working on that. We're trying to improve it. When you look at things, there's a lack of reliability. Our systems do break down more often than they should. The variation wherever you look at you break down the aggregate data and you'll find variation in every piece of data that we look at. I've spoken about the perils of centralization, and from a specific improvement perspective, hard to sustain. Much easier to improve something than to sustain it in my experience. So with all this focus on finance and controlling staffing levels, I think clinical voices, and that's all clinical voices, tend to be outnumbered. We have a system very comfortable, I think, with firefighting, and not so comfortable really with the detailed process improvement that we need to do to make patient care more effective and make our jobs more satisfying. So, and then also we have a future health committee in the Iraq, so going to look 10 years down the line, which is very welcome. That's the kind of timescale we need, maybe even 20 years down the line. But there's a big focus on that committee, and there's a big focus politically generally on changing the structures. Changing the structures, you know, sometimes maybe the structures are part of the problem. Very often it's almost irrelevant what structures you have. And I've worked in the NHS, and I remember various structural changes with different governments there. And the old NHS hacks who I worked with say, oh, well, we're back to 57 there, or we're back to the structures of 62, or, you know, because there's only so many structures you can have, and you just revolve them around, really, as distinct from the kind of cultural change I think that we all know we need. So what's been our response to this? It's been a framework to try and bring together what we believe are the kind of key drivers of a sustainable improvement in healthcare. And that's to try and see if we can put it out there, prove it, test it, and see if we can get the healthcare system to orientate its thinking around these drivers and to really think about putting quality really at the centre. And we produced this introduction to the framework, and we're now at the stage of testing it out. And it's based around 6 drivers, which are not rocket science. We looked at models elsewhere, we consulted widely on it, and we drew on the experience of working on improvement to this point in time. And the 6 drivers are very obvious. I think really leadership, which we've talked about, and I'll come back to briefly. Person and family engagement, staff engagement. I think that's really the core for me. Using an improvement method, not just trying to make it up as we go along or tell people what to do, but actually have a changed approach that's based on some kind of method that's been tried and tested. Measuring for quality rather than pass, fail, and I'll come back to that in a second as well. And having our governance structures really with a clear focus on quality. So we post Orsa Tracta, we set up a team to, for the first time, go around and go into intellectual disability services to see to what extent variations of that, you know, kind of distressing picture of care might exist in other settings and what we could do about it. The improvement team was a partnership with the Social Care Division, visited 218 sites and applied the framework as a solution, because what it came up with was gaps in leadership, staff not being listened to, service users and families having no say whatsoever, no clear governance for quality, not measuring anything that really tells you what's going on, and having no approach to change. So we were a bit surprised that it so neatly fitted the framework, and that then we applied the framework as a solution. We gave practice support. We went around and sat in and worked in settings, training and some tools for change. And inspection outcomes in the sites that we've been working in have this is as good a measure as you come up for the moment anyway, a much higher degree of compliance with the standards expected by the regulator. So some early evidence that maybe it helps. So we were trying to translate it now into 2 acute hospitals and a community healthcare organisation, try to generate a quality conversation on those bases, try and see if we can use it to achieve sustainable improvement rather than, you know, a short-term project that you go back 2 years later and it's all gone. So we're doing some work on all the 6 drivers as well, and we have people working on them. Very small numbers of people, may I say, and Juanita, who's be speaking to you later, is one of those very skilled people who do work in the division. But similar to what Abigail has been talking about, we're not into heroic leadership. There's a lot of it about, so it's going to be a hard thing to talk people down off the pedestals. But we believe in distributive leadership. We believe that everybody is really potentially a leader, and that potential is unrealized in an environment where people feel, and as we found from the staff survey, which we'll be publishing over the next few days and weeks, that people feel, it came up this time with 33% of staff didn't feel involved in any decisions that affected their workplace. Or in other words, they felt completely disempowered to influence their own conditions of work. That's unsafe, unhealthy, and we won't retain staff in that kind of environment. 49% did not really feel valued or recognised. So the flip side to this is probably about 40%, because I think there's about 10% were undecided. 40% did feel valued and recognised. So that, okay, is that good? No, it's not good. Everybody should feel valued and recognised. So there's a couple of findings there that I think you'll become acquainted with, that I hope act as a kind of lever for a completely different approach to both leadership and staff engagement. So we're promoting a different form of leadership and proper walk-arounds by leaders. Get out from behind the computer. Free up the front line. I mean, the leader's main job, in my way of looking at things, is to get obstacles out of the way of the front line doing their job. And sometimes it feels like they do the opposite. So, the no can do, we have to try and get past that. So we need to distribute decision-making power. Around person and family engagement, we've been promoting person-centric culture program, which is just kicking off again in intellectual disability service, but we'll spread it out into the mainstream system, and it builds on the work that Florence Nightingale have been doing with us as well, which has been very, very positive. We're promoting patient for and different ways of getting the patient voice and service user voice into the mainstream. An example of person-centered care I use is Yvonne, who is the catering manager in Shaen in Portlaoise, a long-term care facility, and one of the people who lived there couldn't get out to their daughter's wedding because they were just too infirm and it was going to be too stressful for them. So they ran the wedding again in the centre, and the cake that she baked was significantly nicer than the cake at the main wedding. So the happy couple said anyway. So and it certainly looks pretty good. So I mean, that's just an example. You come across it all the time. We like that to be the norm. In very stressful environments, it's hard to go that extra yard. That's an incredible person-centered effort in my book. And I've seen examples of people bringing horses into the, well, not quite into the intensive care unit, but getting people connected with their horse again, or dogs, or whatever else. And it's just going the extra yard. And we'd all like to do it all the time, and I'm sure that's what we go in to do, but sometimes it just gets squashed out. In terms of staff engagement, there's massive evidence to show if we have a properly engaged frontline staff, care will massively improve. And we don't currently. The staff survey shows that we don't, that they feel disempowered. So we've been doing a few things around mobilising the frontline in Kerry University Hospital, Schwartz-Rands methodology, which we've partnered with the Point of Care in the UK to bring to Ireland, and a whole series of staff listening exercises to try and waken people up to the idea that the only people who understand frontline care are the people who work there. So really, if I'm going to be a leader, the leadership I need to bring to bear is not that I know the answers, but that I know where to find them, and that's at the front line. So that's the pictures of Schwartz-Rand and Blackrock Hospice, and I attended it that day, and I found it very moving and powerful, and I think it's just one of a number of methods that we can use to allow staff to hopefully feel valued, really fundamentally, but also to develop a kind of a greater coherence in your staff group and an understanding of each other's realities, which I think sometimes we forget when we have a row with somebody, that what they might be dealing with. And then in terms of frontline ownership, we've sponsored Michael Gardam, who I think is involved over the next couple of days here in the College of Surgeons, and Leah Gitterman, two great people from Canada who came over, and with Juanita implemented an approach to mobilising the front line in all its glory. That's everybody in the front line, that's catering staff, as I've said, porters and everybody else, and really changing things. That's our National Staff Engagement Forum. Tony O'Brien there on the right, my left, looking very happy. It's just another example of it's a mini HSE that we've engaged to ask them what we need to do to address issues like that are coming up in the staff survey. So let the staff themselves tell us what we should do, rather than say, oh, we need to do this, that, or the other. Using improvement methods, we've trained a whole load of people, and I've again mentioned some of the work we've been doing in partnership with the RCPI. We've trained a whole load of staff in quality improvement methodology. We've a collaborative on reducing pressure ulcers with very good results, also using the same methodology basically, and another collaborative on reducing or improving thromboprophylaxis. Measurement for quality, I could talk to you for hours about measurement for quality and what we currently do and where we need to get to. It's a big trip. It's a long distance we need to go. We have a lot of focus on traffic lights, point-in-time data, arbitrary targets, and grossly aggregated data. Let's be honest, that's what I deal with, and that's why I can't answer Tony O'Brien's question when he asks me, where are we in relation to quality? So we need to move to quality profiles, new KPIs. We need to modernise our whole performance report. We need to use modern measurement techniques like SBCs. And this is just an example of some of the nursing metrics which you'll be very aware of, which is a fantastic initiative and one that we really support and really starts to look at things that are really important to patients. So, but one of the flip side to that is that, as with many of our data, we apply traffic lights to it, because it's a way of immediately visualizing. It's a visual aid to say, are we in difficulty? So the green light is when we break open the champagne and it's all going terribly well and we have a big party. The red light, then, we all beat each other up and recriminate and wail and gnash our teeth. In fact, when you put control limits around that, and that's real data, you find that actually we should have left the champagne on ice and not really beaten each other up either, because it's all natural. There's massive variation in healthcare that's inbuilt and expected. And it's when it goes outside the control limits and you actually can look at it over time and put in control limits, you start to find out when something is really a signal of something going wrong. Because otherwise, what we do is react to noise. That's all noise. It's not a change in performance. It's just bouncing around. But we still got a green and a red traffic light out of it. So anyway, and then grossly aggregated data, we want to break it out into things like this funnel chart, where you can start to see, and the hospitals are named there, who are kind of outliers, both positively and negatively. Not with the view to saying, we're going to fine you or fire you or whatever, and there's great big focus on accountability, as you've seen over the last couple of days, and accountability is important. But with the view to saying, okay, what's going on here? Let's explore it. Let's find out, is it a data problem? Is it a care problem? If it's a care problem, let's address it. So normally what we do is we look at all that data all squashed together and we look at it as a national average. And you can see how little that tells you when you break it out, how much more you can learn. So that's where we're trying to, it's a lot more work, all of this, but it's the work that we've got to do. And that's just putting in the target. So the other thing about that is you put in a target and a limit, so you achieve 80%, and we all go to sleep, or we clap each other on the back and we go off and we do something else. It either drifts back down again, but we also forget the 20% who were failing. So better should have no limit, and that's a bit of a problem with targets. In terms of governance for quality, we're trying to put together an approach to really embed quality through structures and processes of care. We've worked with boards to develop materials about how some of the boards that we have in the voluntary hospitals and other settings might really become more evidently involved in the quality of care. And it's interesting when you start, even with board institutions that have been in place for 100 years or more, how far back they are and how much support they actually need to get into a space where they're looking at data like I showed you there. They're starting to see where they stand in relation to other similar providers. They start to understand then, actually we are doing okay here, or maybe we need to do something a bit better. Because if you're on a board, and I'm on a couple of boards, you have a responsibility to know that, because there's nowhere to hide when something goes wrong. And we're trying to create these executive quality committees, and we've also tested that out in primary care as well. We have a national patient safety program. I've alluded to a couple of the initiatives there already, so we're working on reliability as well as improvement. As a GP, I like cartoons and anything for a gratuitous joke at my own expense. It sometimes feels like that down in Merchants Quay, where you're kind of bombarded and with everything under the sun. But there's obviously a role for generalists and specialists, so maybe this guy could do a bit better than that. And coming back, I think, to Helen Bevan's kind of work that Abigail alluded to, we really need people who are going to swim against the tide and challenge and question and be awkward and, not just gratuitously awkward and unpleasant, charismatically challenging and awkward. That's what I'd kind of put it. So if you can achieve that and swim against the tide, we'd like to support you. So thank you very much indeed.